Welcome to another episode of Fork Candles, where we explore medicine, child neurology, and critical appraisal skills. As always, this is an educational endeavor and should not be interpreted as medical advice. Each patient and situation is unique and should be addressed by your personal healthcare provider. The paper I have for you today is the NEOLEV trial, comparing Levetiracetam versus Phenobarbital for neonatal seizures. First things first, let's go ahead and look at the comparison arm. They were loaded with 20 milligrams per kilogram of phenobarbital over 15 minutes. If the seizures did not stop 15 minutes after that one finished, then they were given another 20 milligrams per kilogram load. If the seizures did not stop 15 minutes after that one finished, then they were switched over to Levetiracetam and given 40 milligrams per kilogram. If that failed, then another 20 milligrams per kilogram of Levetiracetam was loaded. If both drugs failed, then the neonates would default to the institution's protocol for the next medication. If the seizures initially stopped with the phenobarbital load, then they were put on a maintenance of phenobarbital of 1.5 milligrams per kilogram every 8 hours. The loading dose of phenobarbital in this trial is the standard of care. The maintenance dose, however, is not. Due to the long half-life of phenobarbital, normally the maintenance dosing is roughly 2.5 milligrams per kilogram every 12 hours, and it is also titrated to avoid side effects while also maintaining therapeutic levels. This deviation was implemented to maintain blinding because Levetiracetam has a shorter half-life and requires every 8-hour dosing. Maintaining blinding in these types of trials is absolutely critical, as I will discuss later. And I do understand the rationale of using smaller doses of phenobarbital and giving it more frequently, rather than trying to give large doses of Levetiracetam over longer periods of time. With that said, when the standard of care is changed, it is no longer the standard of care. And the burden of proof is on whether or not Levetiracetam is better than the standard of care. By giving phenobarbital at lower doses and more frequently and not titrating to appropriate levels, there may be more adverse events and less seizure control than might otherwise be seen with standard of care. This always makes it tricky to interpret the results of a trial that changed the standard of care to the benefit of the intervention arm. Moving on to what the investigators chose as the outcome. The primary outcome was the rate of achieving and maintaining electrographic seizure freedom for 24 hours. This, of course, is a surrogate outcome. And I don't know how reliable it is for predicting what we really want to know, which is the long-term neurodevelopmental outcomes for these children. And the authors acknowledge this fact. By using a less effective drug with a better side effect profile might have better neurodevelopmental outcomes than a more effective one, but with more neurotoxicity. To put this into perspective, intermittent diazepam can reduce recurrent febrile seizures. However, due to the benign nature of most febrile seizures and the adverse events associated with this medication, the recommendation is not to start children with febrile seizures on any medication. What's more, the outcome of this study is fairly blunt. For example, having a dozen seizures longer than 5 minutes is very different than 1 or 2 that last 30 seconds each. Yet, as far as I can tell, the outcome in this study does not differentiate between the two. This is unfortunate, as a 2015 study found that increased seizure burden measured as the summation of seconds with electrographic seizure is associated with more severe brain injury and significantly lower performance scores across all domains on developmental screening. This more robust continuous variable would have given us more information than the blunt dichotomous responder rate seen in the NEOLEV trial. Alright, now let's go ahead and look at the population. But before we do that, let's get some awkwardness out of the way. This was a well-randomized trial, but they still chose to test and show p-values of baseline differences. By definition, the p-value is what you see by random chance. Even low p-values would be consistent with random chance, because these neonates were randomized. Of course, baseline differences occur, and these can be corrected for. Slapping a p-value onto the differences adds no insight. With all that said, there's not that much in the inclusion-exclusion criteria that I'm all concerned about, and I urge you to look at the full paper online to look at them in more depth. But in general, they came from 5 California hospitals, their gestational age was between 36 and 44 weeks, and their weight had to be greater than 2.2 kilograms. Of those included, roughly 50% had hypoxic ischemic encephalopathy, and 40% of them received hypothermia treatment. Seizures were defined as an abrupt rhythmic EEG activity lasting 10 seconds, with changes in at least 2 features, including amplitude, frequency, or spatial distribution. Now, this might be surprising to some, but seizures are not black and white, and neonatal EEGs are very difficult to read. So it's not surprising that 10% of the 106 randomized children had to be excluded because 2 of the epileptologists could not agree on whether the children had had seizures or not. Although I don't think this has a significant impact on the overall results, it is humbling to think that 1 in 10 children are being over or under treated because we can't decide whether they're having a seizure or not. Now moving on to the intervention arm. The neonates in this arm received 40 milligrams per kilogram of levetiracetam. If the seizures did not stop 15 minutes after the last infusion ended, they were given 20 milligrams per kilogram of levetiracetam. If that failed, then they were given 20 milligrams per kilogram of phenobarbital, and then another 20 milligrams per kilogram of phenobarbital if that wasn't enough. If both drugs failed, then the neonates were given whatever the institution's protocol was for the next medication. If at any point they responded to the levetiracetam, they were put on a maintenance dose of 10 milligrams per kilogram of levetiracetam every 8 hours. Now you'll hear people complain that the loading dose in the levetiracetam arm was too low for even what was being done at the time that this trial was started. But I just cannot agree with that. There were open-label trials at the time that used half the loading dose and still reported cessation rates of 80%. Now, I disagree with using 20 milligrams per kilogram as a loading dose, but that's neither here nor there. I agree with the loading doses of levetiracetam in the NEOLEV2 trial. Okay, so we've talked about comparison, outcome, population, and intervention. Now let's move on to expectation. How effective should we have expected phenobarbital or levetiracetam to be? The authors hypothesized that phenobarbital would achieve a seizure cessation rate of about 50%. I agree with this conservative estimate. They based this hypothesis on the 1999 randomized controlled trial that compared phenobarbital and phenytoin. It is a conservative estimate because those neonates in 1999 weighed less, were younger, and did not receive hypothermia therapy if they had HIE. On the flip side, the authors hypothesized and powered the NEOLEV2 trial to detect an absolute difference of 28% in levetiracetam's favor, meaning they expected roughly an 80% seizure cessation rate. This is despite them citing the literature with seizure cessation rates varying between 30 and 80%. This reflects the all too common tendency to overestimate the newer anti-seizure medications. For example, in uncontrolled trials, lamotrigine had a 70% responder rate for Lennox-Gastaut. However, when tested in a placebo-controlled trial, it was only 17% better than placebo. Based on the long history of underwhelming results when comparing anti-seizure medications for efficacy against each other, my actual expectation prior to this trial would have been that levetiracetam had about the same efficacy as phenobarbital. Now with our expectations in place, we are ready to look at the data. Phenobarbital demolished levetiracetam. 80% of the neonates receiving phenobarbital achieved seizure cessation for 24 hours, while only 28% did in the levetiracetam arm. I did not expect this wide of a gap at all. Looking even closer, levetiracetam looks like absolute garbage. 93% in the phenobarbital had seizure cessation within 1 hour compared to 49% for levetiracetam. 64% in the phenobarbital group remained seizure-free for 48 hours compared to just 17%. 90% of neonates with HIE treated with hypothermia met the primary outcome of 24 hours of seizure freedom compared to 35% in the levetiracetam arm. When looking at adverse events, I like that the authors broke it down into comparing the randomized groups regardless of receiving both drugs, and then also comparing those that only received phenobarbital and those that only received levetiracetam. Since the neonates in the levetiracetam group responded so poorly, more of them ended up receiving both drugs. Focusing on the randomized groups comparison, more neonates randomized to the phenobarbital group had episodes of hypotension, 17% versus 5%. Subsequently, the requirement for vasopressors was 31% in phenobarbital compared to 16% in levetiracetam. More sedation-related adverse events were seen in phenobarbital, 19% versus 11%. More of them had difficulties feeding, 17% to 9%. And as would be expected, the magnitude of these differences increased when looking at those neonates that only received phenobarbital versus those that only received levetiracetam. These did not reach statistical significance because the numbers were so small, but these are well-known side effects to phenobarbital. It is worth pointing out that there were more deaths in those randomized to levetiracetam, 8% versus 2%, and more heart-related abnormalities, 5% versus 2%. Again, none of these were statistically significant, and the levetiracetam is not associated with increased risk of death or heart rate abnormalities. All right, time for some final thoughts and answer the what now, what next, and set my goal for when I change my mind. I thought this was an amazingly well-conducted trial. The results are the best available evidence that phenobarbital is far superior than levetiracetam at stopping neonatal seizures. The blinding was absolutely crucial, and as mentioned previously, doing these studies without proper blinding can produce terribly misleading results. For example, multiple unblinded and uncontrolled studies and case series of levetiracetam and neonatal seizures showed cessation rates in the upper 70s to mid 80%, which was 10 to 30% more effective than phenobarbital in those studies. Stop for a second and think what this means. Unblinded clinicians in daily practice are experiencing almost the opposite of what the NEOLEV2 trial shows. They are under or over-calling seizures based on the medication, and they are getting it wrong. In the end, though, we are still left not knowing the only outcome that matters, which is the long-term neurodevelopmental outcomes. That said, most neonates ended up getting phenobarbital anyways, because levetiracetam was absolutely garbage. Therefore, arguments about adverse events and neurotoxic effects of phenobarbital are moot. From the standpoint, this study supports phenobarbital remaining as the first-line therapy in neonatal seizures, especially when more and more evidence supports coming off anti-seizure medication sooner rather than later, in the setting of quickly controlled neonatal seizures. This should lessen concerns for chronic exposure decreasing cognitive ability. As far as what comes next, the authors discuss the possibility of increasing the dose of levetiracetam to much higher levels. They cite papers giving doses as high as 275 milligrams per kilogram per day. These were case series, and I'm very skeptical that higher doses will significantly close the chasm of effectiveness seen in this study. As far as setting my goalposts of what would change my mind, you always have to set a goalpost, or you'll end up being a hyper-adopter of everything shiny and new, or a crusty old curmudgeon that never changes your mind. No study is perfect, so what would change my mind on levetiracetam becoming the first-line agent? Right here, right now, I will say I will change my mind if a superiority trial is conducted as well as this one, but with long-term neurological outcomes showing that levetiracetam is superior. In the short term, I will be persuaded to change practice by a non-inferiority trial with an inferiority delta of 5%, of an outcome that more robustly captures the seizure burden rather than a dichotomous responder rate. So that's it for now. Please let me know what I overlooked or got wrong in the comment section down below. And remember, as always, human diseases and disorders are problems to be solved, not contests to be won. Let's help each other solve them together.